class, we'll learn about cavernous hemangioma. Cavernous hemangioma are benign, grow slowly, and usually become symptomatic in middle life. Most occur in women. They most often lie within the muscle cone, producing axial ptosis, hyperopia, and in many cases, choroidal floats. Unlike capillary hemangiomas, they do not tend to regress spontaneously. Surgical excision is usually successful and is indicated if the patient is symptomatic. Cavernous hemangioma is the most common benign orbital tumor in adults. It comprised 3.1 to 9% of all histopathological prone orbital tumors in 5 sterols. It most frequently occurs in patients 40 to 60 years old. Rarely, cavernous hemangioma can occur in children. Unlike capillary hemangioma, it's not associated with the presence of hemangiomas where elsewhere in the body. Clinical features. Orbital cavernous hemangioma can occupy an intraocular or extraoral position in the orbit. When the cavernous hemangioma is located intraocular, it leads to a slowly progressive axial ptosis. When it's located extracorneal in the orbit, the displacement of the globule is opposite the position of the tumor. Rarely, a cavernous hemangioma persists as a lamellar gland mass or as intraocclusion tumor. A palpable mass is rarely present. There are usually no significant inflammatory signs, such as eyelid edema or conjunctival injection. Visual acuity is usually good, unless the cavernous hemangioma compresses the optic nerve. When the tumor is located in the victory of the globule, it may induce hyperopia and choroidal floats. It's interesting that the hyperopia and choroidal flows may persist, even after complete removal of the cavernous hemangioma. Ocular motility may be slightly limited. Cavernous hemangioma is typically a solitary outlated tumor. However, rarely bilateral and multiple hemorrhages have been reported in the same patient. Multiple orbital cavernous hemangiomas may occur as a sporadic lesion or in associated with McAfee syndrome and blue rubber blue nasal syndrome. Radiologic features. A-mode ultraspectroscopy demonstrates medium to high internal reflectivity. B-mode ultrasound shows a regular outline with sharply defined borders and moderate occlusive solidity. CT and MRI shows a well-circumscribed round to ovate orbital mass, usually occupying the intracoronal space. The cavernous hemangioma usually spares the triangular space in the orbital apex, although exceptions exist. On MRI, which details internal tissues features well, cavernous hemangioma has a heterogeneous structure. The tumor is isotension to the cerebral gray matter and extraocular muscles on T1 images and hypervisions on T2 images. On contrast injection, the cavernous hemangioma shows progressively filling and enhancement. The interstitial patchy enhancement increased gradually and becomes homogeneous. This pattern is consistent with the pooling of contrast medium in the cavities within the lesion and is considered to be characteristic of cavernous hemangioma. Other orbital tumors may display similar characteristics. The different diagnoses of well-circumscribed orbital lesions on CT and MRI include cavernous hemangioma, schwannoma, fibrohistiocytoma, and hemangioma, and certain mastemic lesions. However, cavernous hemangioma is the most frequently encountered well-circumscribed orbital lesion. Morphologic features. Grossly, the orbital cavernous hemangioma is a scapula mass. The lesion is purple and has a spoon-like consistency. On a cut surface, it displays numerous activate vascular spaces. Histopathology. It consists of large congenital vascular channels separated by thin fibrous septae and flattened endothelial cells lining the vascular channels. There can be smooth muscle in the wall of blood vessels. There may be a few inflammatory cells. Foci of lymphocytes are absent or separate in contracted to lymphoma. Management and prognosis. The treatment of cavernous hemangioma is surgical excision of the tumor. Let's see a video. And sometimes an asymptomatic lesion located in the posterior orbit can be observed conservatively for signs of optic nerve compression and visual loss. There are several surgical approaches for the excision of larger symptomatic lesions. A carcinal or a conjunctival approach can be used. A carcinal approach may provide better exposure of intraocular located tumors in the mid and posterior orbits. It's important to use blunt excision to free the tumor from the surrounding attachments. Sometimes, a corbett can be used to assist in the instant removal of the tumor with less bleeding from the surrounding vessels. Incomplete excision of an orbital cavernous hemangioma can result in recurrence of the tumor many years later. Some of these recurrences can later demonstrate spontaneous regression documented on several neuroimaging studies. Therefore, recurrence developing in an incompletely excision cavernous hemangioma does not require immediate surgical intervention. Complications. Complications of the operation include vision loss and intraorbital hemorrhage. Under general anesthesia, eyesight is judged by the size of pupil. For tumors at the orbital apex, the optic nerve may be damaged during the operation, resulting in loss of vision. Dilated pupils indicate the severity of visual impairment. When the blood vessels of the retina are ruptured, a large amount of bleeding enters the intraorbital space, resulting in intraorbital hemorrhage, elevate orbital pressure, exposmosis, and blindness. That's all for this lesson. Thank you for your attention. See you next time.